Good morning, everyone. Welcome to Grand Rounds. Glad to see those of you who are in the audience, and thanks to all of you who are joining us online. I'm Susan Marshall, and I am covering for my good friend and colleague Suzanne Mazur today. We want everyone to know we will do a Q&A after Dr. Galati speaks. And so for those of you in the room, we'll pass around a microphone. For those of you online, feel free to submit your questions in the chat, and you can do that as we go through the program today. Someone will be monitoring the chat for us, and so then we'll bring the questions down at the end of our presentation. You will also get an evaluation at the end of the session. This will be from the CME office, so we really appreciate it if you'll take a few minutes to fill this out. It really helps us improve our program and also maintain accreditation. So thanks for taking the time to do that. As a last note, the planners for Grand Rounds do not have any relevant relationships to disclose. So I'd like to introduce our speaker for today. So our speaker is Dr. Robbie Galati. He is with our Division of Cardiology. Dr. Galati joined our faculty at the University of Washington and came here to Seattle Children's in 2021. He did his fellowship at UCLA and then stayed on to work there for several years prior to coming to being on faculty here at University of Washington and coming up north. His clinical and research interests include procedural outcomes for pediatric arrhythmias, as well as new technologies in cardiac implantable electronic devices. And his topic today is QT, more than just a number. So thanks, Dr. Galati. Thank you so much.
All right. Thank you, Dr. Marshall and the coordinators of Grand Rounds for inviting me to speak. So, yep, we'll be talking about the QTC, which is really more than just a number. So I have no disclosures. So the objectives for today will be to review how to interpret the QT on an ECG. We'll clarify how to make the diagnosis of long QT syndrome. I'll offer a standardized evaluation approach and how to screen at-risk newborns. And we'll present recent data on sports participation in this population. So to give a little historical perspective, long QT syndrome was first described in the American Heart Journal back in 1957 by Dr. Jorvel and Dr. Lang Nielsen in Sweden. The case report was of a 3-year-old infant who had congenital sensory neural hearing loss and had fainting attacks that were triggered by exertion. At 9 years of age, during one of the attacks, the patient did not recover, and on arrival to the hospital, he was found pulseless and pronounced dead. They incidentally noticed that he had prolongation of the QT interval on the ECG. The case I described is actually a rare form of autosomal recessive long QT, which makes up a small minority of patients with long QT. However, it was the first reported case. These were the ECGs that they provided in their case report. On the left was the baseline ECG when the patient was first diagnosed at 3 years of age. And then ECG B was from a hospitalization shortly prior to the patient's demise. As you can see on both of them, there is pronounced prolongation of the QT, and particularly on the one on the B prior to the patient's death, there was very severe prolongation. So to understand long QT syndrome, we have to briefly review biochemistry. And in its most simplistic form, the action potential is a change in voltage across the cell membrane of the cardiac cells, mediated by ion channels that allow the influx and outflux of sodium, calcium, and potassium. The rapid upstroke of the action potential is mediated by voltage-gated sodium channels, which allow an influx of sodium. This is a channel that's implicated in long QT3. And then repolarization is primarily mediated by the outflux of potassium through potassium channels, which have multiple components and are implicated in long QT1 and long QT2. So when measuring the QT, something that should be so obvious, so easy, is actually really complex. And when we measure the QT, the leads that are recommended are leads 2 and V5. And the Bizet's formula is what we use to correct the QT for the heart rate. It's the most widely adopted formula. There are a variety of others, but this is kind of the standard. And the only caveat that I always like to point out is that the two inputs are the QT measurements, and it's inputted in milliseconds, versus the heart rate, which is the R to R interval, and that's inputted in seconds. When calculating the QT, U waves should be ignored but bifid T waves should be included in your QTC calculation. And kind of an easy way to differentiate the two is, U waves, typically the T wave will go back to the baseline and then there will be a U wave, or if they're merging together, the U wave is less than half the size of the T wave. Versus bifid T waves, those are T waves with like a little hump in the middle, but the two peaks are similar in amplitude. So just quickly review. So when you're measuring the QT, you're taking the line across the slope of the T, and you are ending your measurement where it crosses this line right here, the TP interval. And so that's the point where your QT should end. This is perhaps one of my favorite studies, which was published back in 2005. And the goal of the study was really to assess physicians from different disciplines in medicine to determine which group was the most reliable in recognizing long QT. So they gave 4 ECGs to 902 participants, of which 442 were non-cardiologists, 329 were cardiologists, 106 were arrhythmia experts, or so EP doctors, and then there were 25 world-renowned QT experts, essentially physicians who have dedicated their life to the clinical care and research of long QT. So in the top left, these were the 4 ECGs that were given to the 900 participants, and then the 4 graphs on the right show the distribution of QT measurement for the different groups. And you can see that cardiologists were essentially equivalent to non-cardiologists. They had a broad bell curve in their measurements. Arrhythmia experts fare a little bit better with a little bit of a tighter curve, and then the QT experts have a better bell curve with a narrow, I would say, closer agreement with each other. And so the conclusion from this was that most physicians, including cardiologists, cannot accurately measure the QTC and cannot correctly identify long QT. And so, my caveat to that is, I'll say, while we as cardiologists perhaps don't do a great job, we are still better than the computer algorithm. The computer algorithm is designed to be incredibly sensitive, thus it's not very specific. So the computer read will result in a lot of false positives. I'll also add that this was primarily based on adult doctors, and I'm sure if replicating the pediatric world, we'd do a whole lot better. So the genetics of long QT. Long QT is such a heterogeneous population, and in great part it's because of the multiple implicated genes and the variable expressivity of the disease. So prior to discussing the clinical presentation of long QT, I think it's important to review the genetics, which will hopefully elucidate the different clinical presentations. When we think of long QT, there's really 3 genes that account for 75% of long QT syndrome. And each of these 3 genes has a different phenotype, which is manifested in their ECG and their clinical course. So KCNQ1 gene is implicated in long QT1, and this accounts for 35% of long QT syndrome. It results in a change in the potassium channel, in the slow-acting potassium channel, and it's a loss of function. KCNH2 gene is implicated in long QT2. This accounts for the 30% of the long QT population, and it results in a change in the rapid potassium channel, and again, it's a loss of function. And then the SCN5A gene is implicated in long QT3, and this is 10% of long QT syndrome, and it is a gain of function in the sodium channel. And again, these 3 genes compose 75% of congenital patients. There are about 5 to 10% of long QT patients who actually have multiple mutations across these 3 genes. Typically, these patients will be associated with a more severe phenotype and often a younger presentation. There are an additional 10 minor long QT genes that have been described. Truly, these play a minor role in the genetic basis of long QT syndrome, and there's newer data that kind of suggests they have a limited genotype-phenotype correlation. There's also 3 multi-system disorders that are associated with prolonged QT, which are listed there. So, diagnosis of long QT. 2 of the best-known clinicians and researchers in the field of QT are Dr. Peter Schwartz and Dr. Michael Ackerman. And I really like this quote from them, and they say, as a reminder, a diagnostic pronouncement of long QT syndrome should be rendered very seldom from inspection of an ECG alone, which is, counterintuitive when you think of a disease that is, named after the ECG finding, but truly it is a syndrome, and it is a group of symptoms which occur consistently together. The reason why you can't use your ECG alone is this chart right here. So there is a significant overlap between affected and unaffected populations, and the ECG is only part of that phenotype. So you can see the bell curve on the left. This is the unaffected populations, people who do not have long QT syndrome. On the right, this is our long QT syndrome, and you can see the gray hashed area. That is the area of overlap. So whenever you have an ECG and it has a prolonged QT, or you're just questioning whether the patient has long QT, you really have to ask yourself the question of what is your pre-test probability? And this is determined by your clinical history. So if you have a patient with no family history and you're just looking at the ECG, the probability of long QT at that point is 1 in 2,000. If you have a patient who has a positive family history that you think is either known long QT or suspicious for long QT, at that point, your pretest probability could be as high as 50%, as most of the long QT genes are autosomal dominance and inheritance. So really, your clinical history should be driving your suspicion, and it shouldn't be your ECG alone. So if you have a patient who presented with ECG, the main questions to ask are, what was the description of the event? Are you suspicious that this was actually arrhythmic, or was this non-arrhythmic, more consistent with a vasovagal type episode? If the patient that you are evaluating is presented with an ECG, the question to ask is, why was the ECG obtained? Was the ECG part of a screening event, or was the ECG obtained because of a family history? And was that family history for, again, known long QT syndrome, sudden death, unexplained accident, or somebody who drowned? So it should really drive your interpretation of that ECG, of that QT on the ECG. When you have a prolonged ECG, really the goal is you're trying to differentiate, is this just QT prolongation? Are you at the upper end of normal, or is this a long QT syndrome? And so the standard cutoffs we use is 440 in the male sex, 460 in the female sex. These represent the 95th percentile. 470 and 480 represent the 99th percentile. But truly, until you don't get above 500, that's the threshold where the pretest probability then favors long QT syndrome over you just having found a QT outlier. When we see patients in the EP clinic and we're evaluating them for long QT syndrome, we go through the scoring system. It was developed by Peter Schwartz's group back in the 80s. And what they do is they assign points based on findings. And you can see there's a number of ECG findings, a couple of them just on the QT interval, a couple of them based on arrhythmias or the way that the T wave appears. But you'll also see there's a big component, a lot of points that get assigned on the clinical history. So again, just stressing on the fact that clinical history really should drive your interpretation of the ECG. The scoring system gives you a probability from low to high of the patient having long QT syndrome. What they don't give you readily is what is that probability. So if you have an intermediate probability, it actually means 10% chance. 10% chance of having long QT syndrome, 90% chance of being just normal. Versus if you hit the 3.5 points, that jumps up to 90% probability of having long QT syndrome. So you can see there's a huge gap between 10 to 90%. So, short score is important, has a utility to it, but needs to be taken with somewhat caution, and again, in context of their clinical history. The Heart Rhythm Society consensus statement for how long QT is diagnosed is, if in the presence of a long QT score more than 3.5 in the absence of secondary causes of QT prolongation, or if you have a pathogenic mutation in one of the big 3 long QT genes, or if you have multiple QTs that measure more than 500 milliseconds on repeated ECGs. Again, that 500 is that threshold where your probability of having disease is greater than just being an outlier of normal. They also say, if you're in that 480 to 500 range in the presence of unexplained syncope and without any secondary causes, then you can get the diagnosis of long QT syndrome. And so, on every single statement, they highlight secondary causes. And so, important to review, what are the secondary causes of QT prolongation? Anything that perturbs the autonomic system can affect the QT interval. And the number one cause of transient QT prolongation is going to be secondary to vasovagal events or syncope, which adds to one of the diagnostic challenges of this disease, because oftentimes, patients have a syncopal event, they go to urgent care, they go to the emergency room, ECG is obtained, and it shows at that point a borderline or prolonged QT. And so the question is, do they have long QT syndrome or are they normal? And so I will caution, again, your clinical history should drive your interpretation of the ECG. So if the description of the event is suspicious for vasovagal, your pretest probability really does not change. It remains at 1 in 2,000 chance that this is long QT syndrome. It's more likely going to be outlier of normal. There are a number of medications which can cause QT prolongation. The website's listed there, Credible Meds. They actually have a nice app now, just a screenshot over on the right, where you can look up all the medicines. There's 301 medications that are currently listed. All of them predominantly cause a QT prolongation by blocking the rapid potassium channel. Other causes of secondary QT prolongation are electrolyte abnormalities, predominantly hypokalemia and hypomagnesemia. And then just one last caution, cardiac arrest, again, can cause prolongation of the QT. This one can be particularly challenging because oftentimes we're looking for a cause of that arrest, but when patients arrest, there's autonomic system is perturbed, so that can kick out the QT interval. So it's really what the leading events were up to the cardiac arrest or what the family history is that should drive your interpretation of that QT. So finally, when we get to a patient who we have a high suspicion for a long QT, they have a positive family history or they have a suspicious clinical history, what is the workup? When we see them in cardiology clinic, these 4 tests is what we do. We'll get an ECG, we'll do our Holter, we'll do a treadmill test. For treadmill tests specifically for long QT1, we're looking for a prolongation of the QT during the recovery. So after they stop running, that's when their QT will remain prolonged. And then at this point, if you have a high suspicion enough, you should be getting your genetic testing. So, that's kind of the standard approach to your average, school-age child to your adolescent. But I did want to, do one plug. We oftentimes have newborns who are at risk for having long QT because of their family history. And so this was a nice study that was just published in 2022. And it really looked at the diagnostic accuracy of the ECG in making the diagnosis of long QT in newborn infants who had an affected parent. So they included 74 infants whose parent had a genotype positive diagnosis of long QT syndrome. So this group, without you knowing anything, they had about a 50% probability of carrying a pathogenic mutation. The ECG was obtained at 48 hours of life, and the ECGs were independently reviewed by the Mayo group and the QT remeasured, and then genetic testing was obtained for all of the infants. So among the 74 infants that were included, 50 of the patients ended up carrying a pathogenic mutation in the genotype, in the gene similar to their parent. For these patients, you'll see their mean QTC was 500. For the genotype negative infants, which was 24 in the study, the mean QT was 455. So you look and you say, great difference. But then you look at the standard deviation, you'll see that there's huge standard deviation, which is reflected in the 2 bell curves, which similar to all ECGs, there's huge overlap. And so ECG alone was unreliable in this population for making the diagnosis. And so this is a table out of the study, and they looked at how the different QTC cutoffs affected the diagnostic accuracy of the ECG. So focusing on 440 as a cutoff, which has previously been validated as the 97th percentile for 4-day-old infants. And again, the study was 2-day-old, so there's some difference there, but this is a commonly validated number for infants. The ECG alone was 88% sensitive, but incredibly nonspecific at 29%. So there were a lot of wrongly diagnosed infants, so overdiagnosis and false positives. If we bump up our QTC threshold to 470, we diminish our sensitivity, improve our specificity, but at that point, again, diminishing our specificity, so we are missing a 22% of genotype positive kids. So what were the conclusions from this study? Infants born to a genetic confirmed parent of long QT syndrome, they have a 50% probability of having disease-causative gene. UCG alone is unreliable, so genetic testing should be initiated early. They also added this caveat, which I like, is that the newborn should be allowed to bond with their mother and do not need to be transferred to a monitored unit unless there are other indications to do so. And so this was a proposed algorithm that they've been using at Mayo, and that was proposed in their paper. So ECG is obtained at 48 hours. They used a QT cutoff actually of 480. So again, they sacrificed their sensitivity but made it more specific. If it was more than 480, they recommended repeating the ECG on day 3 of life, so at 72 hours, so 1 day later. If it stays more than 480, they recommended initiating beta blocker treatment while waiting for your genetic testing. As opposed to if your QTC is less than 480, patient can be discharged. You repeat an ECG at their first well-child visit, and as long as it stays less than 480, you just wait for your genetic testing. So the only, one of the reasons why I wanted to highlight this paper is I think this is an exception. With most patients, it's really your clinical history. But in this at-risk population where they have such a high pre-test probability, really your genetic testing should help drive the way you think about it and should drive the diagnosis. So the different phenotypes of long QT syndrome. As I already alluded to, the clinical presentation is very variable, in part because of the expressivity of the genes. So you're going to have patients which have a very mild or no long QT expressivity, and they may never experience any symptoms. We commonly refer to these patients as our concealed long QT. You also have patients who have frequent episodes of long QT, triggered torsades, and are at risk of having sudden cardiac death. But across the 3 main long QT genes, that long QT 1, 2, and 3, the average age of diagnosis is 14.7. The average QTC is 465, and it's slightly more common in the female sex, which composes 60% of the long QT population. Among patients who get diagnosed with long QT based on a combination of their ECG, genetics, and family history, approximately 30% of them were symptomatic prior to the diagnosis. And symptomatic, they define it as having had a seizure, they had an arrhythmic syncope, they had a fetal arrhythmia, or they previously had a cardiac arrest. For these patients, and again, so they're symptomatic prior to 14.7 years of age, typically they're going to have a longer QT. Their QT presentation is going to be 485, and they're more likely to be a long QT2 or long QT3. When you look at the ECG, it was identified early on that not all QTs look the same. And I like this quote by Dr. Schwartz, who by now you've gathered is one of the pioneers in long QT. And he says, "I don't measure the QT interval, I look at it." That's unfortunately not true for most of us. We can't just look at the QT, so we rely on that measurement. But I think it highlights that from early on, it was identified that there's different patterns that we see on the ECGs. And this paper from 2006 was really one of the early papers in the post-genetic era that highlighted that the different genetics actually have different phenotypes, and they have different clinical presentations, which is also manifested in the way their ECG looks. So when we think of long QT1, we commonly think of these broad T waves, and their trigger for torsade event is going to be exercise, versus our long QT2s, which typically have a notched T wave. And for them, we think of their torsade triggers as being startle, telephone, alarm clocks, postpartum. And then lastly is our SCN5A mutations, which really have this delayed T wave. They have this period of isoelectric where there's kind of a flat line prior to the T wave. And their triggers for torsades is going to be sleep or rest. So the rhythm disturbances that we see in long QT syndrome, the one we all most concerned about is going to be our torsades, which has this hourglass type of appearance. The other finding that we see is T-wave alternans. It is this finding where the T waves will alternate between going positive to negative on alternating beats. This is typically thought of a precursor to our torsades events, but again, in the undiagnosed patient, both of these arrhythmias or findings would contribute to your Schwartz score. And then the last arrhythmia, or one of the other arrhythmias that we see, is AV block. So most commonly going to be 2-to-1 AV block. And so these are patients who have such a prolonged, pronounced QT interval where their sinus beat, sinus P wave, is unable to conduct down the AV node to the ventricles because the ventricle is still refractory. And so as evidenced on this ECG tracing on lead 2, you can see, again, 2 P waves for every QRS. So it results in your 2-to-1 AV block. This kind of transitions us to a subset of the long QT population, the neonatal long QT. And so for this population, I wanted to share a quick story. Sienna was my second encounter with long QT, and I was involved in her care for the first few months of my EP fellowship. I share her story with the permission of her family. And, you know, during her short life, during the 3.5 months that I involved in her care, truly, I learned more about the management of severe long QT from her than I had up to that point, and truly that I have since that point. Sienna was born full-term gestation. She had an in utero diagnosis at a referring hospital for AV block. While in utero, she was alternating between 2-to-1 AV block and 3-to-1 AV block. And shortly after her delivery at the referring hospital, she went into torsades, and she received amiodarone and magnesium. As some of you know, amiodarone, probably one of the worst medications to give in this situation, as it can further prolong your QT. One advantage, it does reduce your torsades, but at the cost of giving you even more pronounced AV block. So it resolved her torsades, but she was now in 4-to-1 or 5-to-1 AV block. She was transferred to our hospital and spent the remainder of her life there, where she was diagnosed with a SCN5A mutation with a very pathologic ECG in course. Unfortunately, she also developed a dilated cardiomyopathy, which can be associated with SCN5A, and passed away while waiting for a heart transplant. But what is unique about her story is her family. In an effort to provide the best possible care for her, her parents reached out, I kid you not, to every QT expert in the world. So at a certain point, Dr. Ackerman, Dr. Peter Schwartz, and Dr. Georgia Brugada were all involved in her care remotely in consultation. In speaking with these world experts on long QT, it highlighted that there was an experiential understanding that patients who present in the neonatal period are much sicker than your average long QT. But it also highlighted that there was a gap in how we counsel these families and then how we manage these patients after the discharge. Do they get a nice CD before they go home? Which medications work best? So these are some of the questions. And so Sienna's case really prompted us to collaborate to publish this experience. And in my short career so far, this is the project that I'm most proud of, and remain eternally thankful to the Ergen family for allowing me to share in their daughter's experience. So up at the top, this was our UCLA group. And then you can see, again, these world experts on long QT. But in total, we had 25 international centers who contributed data to this cohort. We had 84 patients who met criteria. And specifically, we looked at fetuses or newborns who presented with congenital long QT, and they had to have 2-to-1 AV block or torsades, either in utero or in the first 30 days of life. And among our 84 patients that were enrolled, you'll see there were a significant number that had long QT3, so 37, and 35 had long QT2, so long QT1 really made up a smaller proportion. Again, very different than your teenage or adult long QT population, where long QT1 is most predominant. As far as the outcome, over a median of 5.2 years, there was one patient with long QT1 who passed away, and there were 11 patients out of 37, long QT3, who died or received a cardiac transplant during follow-up. And really the only predictor of having a post-discharge event, and the post-discharge event was either cardiac arrest, appropriate ICD shock, or sudden cardiac death, was having a long QT3 genetic. So chart on the left, so this is our Kaplan-Meier freedom from cardiac event as I just defined, ICD, sudden cardiac arrest, or death. And you can see, despite all the infants presenting with the same type of rhythm, either 2-to-1 AV block or torsades, it was really our long QT3 patients who did the worst. And by 1 year of age, it was about 50% of them had suffered a cardiac event. If we eliminate ICD shocks and we only include our patients with death or transplant, same thing. By 1 year of age, about I think it was 75% of the long QT3 patients had either passed away or gone on to transplant, versus our long QT1 and our long QT2 patients who fared much better. And so for these patients, it just highlighted the importance of establishing a quick genetic diagnosis. And if you have the patient with long QT3, kind of the conclusion that we made from the paper was it should drive your decision, and they should be considered for ICD and early transplant evaluation. So when we talk about management of long QT, just like there's such variability in the phenotypes, there's a lot of variability on what your treatment modality is going to be. So there are patients where nothing is prescribed, nothing is really done other than creating a safety plan with the patient and their family. Then there are patients who require medication, with beta blockers being the most common. There's a small subgroup of patients who may require a left cardiac sympathetic denervation for refractory arrhythmias, to medication refractory arrhythmias. And then there's a small group of patients who would benefit from an ICD. This was published on the right-hand side. This is from the Mayo Experience, which came out in 2017, and they show, again, vast majority of patients are beta blocker alone. Next group is beta blocker and an ICD, which composes 13%, and then a significant number, 8% of patients, required no active therapy. So beta blockers, they really changed the survival of patients with long QT syndrome. In the early studies from the 1980s, prior to the beta blocker studies, mortality associated with long QT was, in some cases, reported as high as 70%. And with the introduction of beta blockers, this mortality was decreased to 6%. However, as we all know, beta blockers come in a variety of forms. And so this was a nice paper from 2012 that really elucidated that not all beta blockers are the same. So they took 382 patients who were either on propranolol, nadolol, or metoprolol. And what they found was that propranolol had a significant better QTc shortening effect compared with the other two beta blockers. However, propranolol and nadolol were equally effective in preventing a breakthrough cardiac event, which they defined as having torsades, having an appropriate ICD shock, or having a cardiac arrest. They also found that metoprolol did not fare as well as them, and actually should not be used for our patients with long QT1 and long QT2, as they were at higher risk of having a breakthrough cardiac event when compared to our nadolol and propranolol populations. Other medications that our ICU colleagues or emergency room colleagues may see at times are lidocaine, mexiletine, magnesium, flecainide, and phenytoin. So these are medications that get predominantly used for our patients with long QT3 or when a patient presents in an arrhythmic crisis. The other thing I mentioned is left cardiac sympathetic denervation. So this is a surgical procedure done by open thoracotomy or thoracoscopy for removal of your T1 through T4 ganglia. And the Mayo Experience showed that left sympathetic denervation reduced your norepinephrine release and had a striking antifibrillatory effect. In their paper, they had a small population of pediatric patients. So again, not as vetted in the pediatric population, but has been described. As far as indications for implantable cardioverter defibrillator, there's really only two class 1 indications. So this is going to be for patients with a diagnosis of long QT who have survived sudden cardiac arrest. That's your first one. And then your second one being patients who beta blockade is either ineffective or not tolerated, and they are not a candidate or sympathetic denervation has not worked. Those are really the only two class 1 indications for ICDs. So truthfully, the majority of the population with long QT syndrome, an ICD is not indicated. The last group is this concealed long QT. So these are those patients who have a genotype diagnosis of long QT syndrome, but they may have no phenotype. This actually can make up to 25% of the long QT population. They're at very low risk for arrhythmia, but they are still at increased risk when compared to the general population. So the general recommendation are, avoid your long QT prolonging meds, appropriate hydration, electrolyte replacement, and from a cardiology standpoint, these are the patients that we consider for a stress test or epinephrine challenge. And if either of those are positive, we would consider beta blockade. But truthfully, again, very low risk of arrhythmia. So moving on. Sports and long QT. So to give a little historical context on why this is somewhat misunderstood, a little bit debated, not really that debated anymore, but in 1994, really prior to the genetic era of long QT diagnosis and management, at the Bethesda conference, which was a workforce to determine eligibility for competition in patients with cardiovascular abnormalities, they gave this recommendation, and they said that patients with a prolonged QT or QTU interval are at risk for sudden death, and such athletes should be restricted from all competition. Unfortunately, easy to put into place, and at the time, it seemed like the appropriate recommendation, and honestly, this workforce was chaired by two very well-known, respected electrophysiologists at the time, and this recommendation was in place for less than 10 years, but it has taken 20 plus years to kind of undo this recommendation. This is the most recent, the 2015 recommendations, and you can see the chair for this was Dr. Ackerman, again, one of the best known physicians in long QT research, and they were looking at patients with long QT syndrome and other channelopathies, and what they said is asymptomatic athletes with genotype positive but phenotype negative, again, are concealed long QT patients. They can participate in all competitive sports with appropriate precautionary measures. Precautionary measures kind of seems obvious, but it's avoiding those QT prolonged meds, making sure they are electrolytes and hydrated. They should avoid or seek treatment if they have hyperthermia or training-related heat exhaustion, as that can incite arrhythmias. And then this is probably the one we run into the most difficulty, though, is patients with the diagnosis really should have a personal automatic external defibrillator as part of their protective gear, or the team should have one. I think this is becoming more adopted and more widespread, but it is still one of the struggles. And then lastly, is having an emergency plan, which should be developed with both the patient, their family, and the school. But for, again, asymptomatic patient should be allowed to participate in all sports. Jumping over to the symptomatic patients of long QT syndrome. So these are the patients who have an ECG that manifests, meaning their QT is prolonged, it's more than 470 or more than 480. The recommendation is that they may be considered for physical activity for competitive sports after the institution of treatment and appropriate precautionary measures. So these are our patients who we will typically treat with our beta blockers. You want to make sure that they remain asymptomatic for at least 3 months. Oftentimes we will put them on a treadmill, re-exercise them prior to clearing, but they also should be allowed to participate in sports if they are compliant with their medication and asymptomatic for 3 months. So why the change in recommendations? There's been a number of studies looking at this question of sports participation. So this study published in 2015, it was a collaboration of the Philadelphia and Cleveland groups, looked at a pediatric cohort. Specifically, they included 103 patients who participated in either competitive or recreational sports. And among this population, it was 60% long QT1, which you hopefully remember are the patients most at risk for arrhythmic events with physical exertion. And in this study period, there were no patients who had long QT who had cardiac symptoms during sport participations, meaning they had no cardiac arrest, they had no torsades, no appropriate ICD shocks. The one caveat I will add is all of these patients were seen in a tertiary referral setting. They were appropriately prescribed beta blockade if indicated, so they had that safety plan in place. This is a second study that was just published in 2022, and it was out of the French experience. Specifically, they looked at 170 adult patients who participated in sports after their diagnosis of long QT syndrome. And during their follow-up period, only one patient suffered a cardiac arrhythmic event. The patient had an ICD, and it was in the setting of beta blocker noncompliance. So they reported a cardiac arrhythmic event rate of 0.0007 events per year. So again, incredibly safe for patients with long QT to participate in sports. So kind of the takeaway message from this is sports are safe. If the patient is followed by a cardiologist, ideally electrophysiologist, if they are compliant with their medications, and particularly if they are prescribed a beta blocker, if they are hydrating and replacing their electrolytes and taking precautionary measures, and then if you have a safety plan in place that involves an AED as part of their own personal protective equipment or for the teams. The one caveat to kind of this is probably swimming. In one of the sub-statements from the guidelines, it says, patients with long QT1 should not participate in competitive swimming if they have been previously symptomatic, just because of the high stakes nature and probably shorter response while they're in the pool. As far as outcomes in long QT, so as I already mentioned, pre-1980s, long QT morbidity mortality was as high as 70%. So this paper in 1985 was really a seminal paper, and it showed a dramatic reduction in mortality with long QT patients who were treated with beta blockers. And then over the next 20-some years, you see that mortality rate, which is sudden cardiac death, has continued to decrease. And BCEs is our breakthrough cardiac events. Same thing, has continued to reduce down to 1.3. I think this, is really the result of better understanding that there are different phenotypes of long QT, and there are medications which work better for the different groups. And also, I will also add, in these later two studies, the denominator has significantly increased. There's now this concealed long QT population, right, where they have a genetic diagnosis but perhaps never show a phenotype, and those patients are included in these studies, and they were not in the 1980s. A little bit small, my apologies, but in the top left, so this is looking at the entire long QT population, again from the Mayo experience from 2017, and you can see, independent of their symptoms or their genetics, the event-free survival at 10 years is 90%, meaning most patients will never have an arrhythmia or cardiac arrest or any kind of event. If we divide those patients out further between the symptomatic patients and the asymptomatic patients, you'll see again, asymptomatic, extremely low risk, 97% with no events at 10 years, not as good as a general population, but still incredibly safe, versus our symptomatic patients, which don't fare quite as well at 10 years, about a 30% chance of them having a breakthrough cardiac event. And then when we divide the population by genetics, kind of, what I've alluded to multiple times now is long QT1 patients tend to fare the best in the top with very few events. Long QT2 don't do quite as well as our 1, and then long QT3, as well as patients with multiple mutations, are really the ones who fare the worst, who have typically the most cardiac events. So, in summary, the takeaway points. Clinical history is really essential to when you are interpreting your QTC on an ECG. Long QT syndrome is an incredibly heterogeneous diagnosis, and beta blockade, predominantly nadolol and propranolol, are the mainstay of treatment, and sports are safe in patients with long QT syndrome with appropriate counseling and planning with the family. Thank you.
Glady, thank you so much. That was wonderful. I know we all learned a lot. I am going to start in the room to see if there are questions in the room, and then I will also work with Emily Rice to answer questions in the chat. So can I start with somebody in the room who might have a question?
Thanks, Robbie. That was really clear, and I learned a lot, actually, things that I may have forgotten or never knew. This is Mark Lewin, by the way. So I have a question that might help us when we're thinking about families who have who come in with a family history, and then they come in with their child for evaluation, or in my case, a fetus for evaluation. In terms of counseling them, does the phenotype of that first degree family member predict the phenotype in an affected individual? So you test somebody after you see them and they are genotype positive. Can you then from that predict anything about phenotype based upon how the severity of the family's phenotype?
Family history, the family history, if other members have had a cardiac arrest or cardiac event, that does predict a more malignant course for the offspring, for the children. But really, when you're looking, especially at that fetal population, if it's a known long QT1, again, takeaway is probably the infant will do well. Interesting enough, that long QT3 population, so that group of patients who do extremely poorly if they present in the fetal or neonatal period, they're actually less likely to have a positive family history. So unlikely to be known. I think it's more likely you'll pick up the diagnosis on your fetal scans.
Thanks. So I'm curious about the sports piece. I understand the competitive swimming issue, and thanks for explaining that. I'm wondering about swimming in general for patients, related, not being competitive, but what about swimming, and what about long distance running when they're going to be out? So how do you counsel patients
I think
for those things?
Yeah, I think that's where you stratify your patients, right? So if they're asymptomatic, meaning they've never had an event, the chance of them having an event is going to be extremely low. And so you're just giving them your good precautions of, appropriate hydration, electrolytes. And even though they, as you said, running, they may be further away, hopefully there will always be somebody around, right? And some way of activating an emergency plan. And for those patients, actually, swimming is not contraindicated. It's really for your symptomatic long QT patients. So prior history of arrhythmic syncope, having had documented arrhythmia, having had a cardiac arrest, those are the ones, swimming, again, with extreme caution. And even for recreational swimming, what I usually counsel to those patients is I tell them, I was like, it's not an absolute no, but don't ever do it alone.
Yeah, that's really helpful. Thanks. Anyone else in the room? We have
one question from chat from Kelly Fawcett. How much should we be concerned about patients on medicines which prolong QTC and who are found on routine EKG to have a borderline prolonged QTC, no symptoms?
So not very, truthfully.
So related to that, what would you recommend if we find that as a provider? Do we refer them to you for further evaluation?
I don't think so. No, I wouldn't recommend it. I think so. Again, you're interpreting that ECG in the context of, why was the ECG was obtained? Was it obtained because of family history? Completely different. If it's just, I got an ECG, because the patient is having some palpitations, your chance of picking up long QT is very small. And if they are not having any symptoms that make you concerned for arrhythmic syncopes, I think just you can repeat an ECG at a time interval. There's no set time interval, 1 month later, 3 months later, whenever works. And truthfully, if it stays, normalizes, great, you're done. I'd say if it continues to stay in kind of that upper borderline, above 480, then it might be worth a referral, to us, and, we can go through it. But truthfully, the chance of finding long QT is going to be really low in the absence of those other clinical findings.
That's great, thanks. Any other questions in chat? Great. Any other questions from the audience? Well, Dr. Galati, we want to thank you so much for this wonderful presentation. I know we all learned a lot.